Good morning, everybody. I'm really excited to be here. This is Salient's 8th NAACOS presentation, and it's also my 8th NAACOS event, so I'm excited. And we have a really great panel for you today, a lot of experience that varies from being the Medicaid director in North Carolina to being the COO of the largest independently owned ACO in Palm Beach. And we also have Katie, who's coming to you from Vanderbilt Health Alliance Network. It's a huge hospital network that has many contracts. So whether you're from the hospital-based side or the independently owned side, you have a lot of experience up here that you can reference. So today we're going to talk about the crossover between Medicare Advantage and the MSSP or ACO program. And there's a lot that crosses over, but there's a lot that doesn't. And that's always a problem when you have one population. So, quick intro. We know that value-based payment is here to stay. I know we have Seema Verma who's going to talk in a little bit, but she has time and time again reiterated that we're not changing anything. This is the path forward. Whether we call it an ACO or something else, it's still the same path. Additionally, the Medicare population is the one to focus on because it has extreme growth. Whether you're in Medicare Advantage, there's a huge trend upwards. The population is growing day by day. So this is the one that you need to focus on because it is such a large and unmanaged population. So we're going to talk about a few different points. Firstly, similarities and differences that come to mind off the bat. Some of these you may already know and may have experienced yourselves, but we're also going to talk about the needed or necessary resources and infrastructure, as well as how you negotiate or work with your payers to get some sort of alignment, because parity is really important when you have doctors that are seeing patients and they don't know which criteria they need to fulfill. There's different quality metrics. It can be very, very confusing. So we're going to go ahead and introduce our players. Since we are right near the baseball stadium, we made little baseball cards for everybody. And so we're going to begin with Katie Herron. So Katie comes from Vanderbilt Affiliated Health Network, or we call it VAN for short. And she has 1.5 years experience with VAN in the provider network space, but personally she's had about 15 years of experience there. There have been involved 4 years total with the ACO, and she did 1 year with an independent practice, helped build that from the ground up, and then another year with a hospital-owned ACO. And has a total of 6 years of MA experience. So a lot of experience comes to the table from that end of the table. Next, we have Dr. Gray. He's our Chief Medical Officer at Salient, but has had a lot of other experience, as you can see in his title, MD, JD, MBA. We all wish we could be like that. So he's been involved in population health management, especially from the beginning of the IPA movement. So really deep down in his roots, he's had that foundation. And he was the Medicaid director for North Carolina for 3+ years. And lastly, we have David Klabonis. Welcome. He's from Palm Beach ACO. I'm also in Florida, so we're familiar. And he started in 2012, as did their ACO. This is the largest independently owned ACO. Their their tax number is 1, so they were the first contract in, which is pretty impressive. And they've been involved with Medicare Advantage for about a year. So a little bit of variation across our panel so that if you have any questions that pertain to a certain member, you can go ahead and ask them at the end. So let's get started with our questions, which are really interesting to see the answers to. So the first one we're going to touch upon is the similarities. What are the similarities that you see across your Medicare Advantage and your ACO contracts or your patients that are involved in both? And we're going to start with Katie.
Hi, good morning. So I think between MA and MSSP, it's important to remember that as you manage these populations, that both contracts, while the terms and methodologies can be very different, the goal of both is the same: to reduce unnecessary expenses and improve the quality of care for the patients under those contracts. So the programs that you build and the interventions that you create within your ACO or MSO or whatever your health system can be applied to both. Be it your care coordination team, your transition of care staff. But one that I have found in my experience to be most important to build and implement and apply to both MSSP and MA contracts is your risk adjustment strategy. So to have certified Medicare risk adjustment coders as part of your team, and to accurately assess your patient's acuity of illness burden, and report that to the payers that you're working with.
Absolutely, thank you. So similarities there lie with HCC coding, but more so needing that resource to help with coding. David, can you talk a little bit about your similarities?
Absolutely. So, Katie has a broader network than we do as a network of independent physicians. So while we're large, we have about 400 independent physicians in our network. We don't represent the facility or home health or SNF dollar, but, we were pleasantly surprised that all of the efforts that we had spent creating a high-value network, again, Medicare Advantage, Medicare, these are the exact same populations, but the time that we invested finding and educating the highest quality subspecialists, cardiology, nephrology, to work with home health, SNF, on managing length of stay and the right case mix. It really helped that we had been working on that for 7 years, that when we transitioned over to Medicare Advantage, it was really quite turnkey, and it was following a lot of the same methodologies.
That's good. And you'll notice that it's kind of the chicken and the egg. Which one came first, the ACO contract or Medicare Advantage? And what ground did you have laid out before you started your next one? Or maybe you started them both at the exact same time. But there could be some groundwork that's laid ahead that could help with the other. Dr. Gray, can you touch upon some points for similarities?
Yes, thank you, and good morning. You'll have to forgive the sound of my voice. My voice instructor, Kermit, has been successful in having me match his audio characteristics. Although I will tell you that I am current with my annual wellness visit, and I did have my flu shot for whatever good that did. All right. The similarities, I think, are striking here within the context of the patient, because as physicians, those of you in the room who are, and those who are managing physicians, God bless you, that you will know that physicians generally don't look at the insurance moniker on the chart when they start treating a patient. So the advantage you have, clearly, in treating MSSP or MA patients is the fact that these physicians see the person in front of them as a patient and will treat them uniformly. Now, even though there will be differences, and we'll be talking about those in just a moment, the striking thing is that the thinking of higher level finance people is also in that direction, that there is one patient in front of you, and the quality standards and the administrative standards and the management standards for that particular patient should be the same. Now, eventually we'll get there, particularly as the community ACO begins to focus on the community population that it's responsible for. So the point that I want to leave with you at the very beginning is the individual in front of you is the central standard of practice for all different insurances that may support that person. And the idea in mind is to move the periphery towards the center, not to divide the patient up toward the periphery.
Exactly. It's a good point to make, especially from the physician perspective. I just want to take a minute to announce that we're going to do a raffle at the end. So if you just trickled in and didn't provide us with your business card, Ryan is walking around to collect those. We have a $100 Visa gift card. All right. And also on your tables, you have some folders. There's a worksheet. I'm not making you do homework if you don't want to, but if there are notes that you find valuable that you want to bring back home, you're more than welcome to use that to fill that out. All right, we're going to move on to differences. So there's a lot of differences within your different contracts. A lot of it doesn't align because you have commercial payers versus MSSP, which is the government, and the government is typically your gold standard. They're not the ones that are changing. They set the rules going forward unless we, as part of NAACOS, many times submit requests to change. So let's start with David on this one. What are some of the differences that you've come across and managed in working with these two different contracts?
Absolutely. So we spend a lot of time studying the contract rules and then translating that to effective program tactics. And one of the lessons we've learned, and we see folks that may not spend enough time on this, is the attribution methodology. So which patients that you treat and then which patients you're accountable for at the end of the final reconciliation can be remarkably different. And I can assure you that if you have the absolute best clinical programs, that all of your performance can be erased if the patients you start with is 30-40% different than the patients you end with. So that's a big difference, is Medicare Advantage often has an assignment model where you know the PCP, and that's fixed over the years. And then with MSSP, it's an attribution model where you have to really look closely at the patients you see them consistently so that you get a fair shake at the end, that the patients you start with are consistent at the end.
Absolutely. And also the difference with the assigned methodology is many times the doctor may not have ever seen that patient. They were just assigned to them, whereas in the ACO, you had to have seen them to gain the plurality. So there is a difference there as well with the different methodologies.
Yes.
Dr. Gray, can you touch upon some differences?
It's been said that these are two different patient populations. It's been said that the MA population tends to be a little more highly educated, have figured it out a little more. But I'm not convinced of that. Because, for example, the folks in Florida particularly who are sunbirds, who spend snowbirds or sunbirds, who spend most of their time in Florida and come back in the summer to a more rational climate, have figured out already that they need a very broad network. And so that difference between the MA model, which may have a narrower network in the HMO form or in a limited network in the PPO form, these folks have figured it out as to where they need to be for their care. So this population, I'm not convinced is so much different as it may be similar. Oh yes, we are all different, that's true. But indeed, in terms of our getting health care at a certain point in our life, that is, I think those populations are pretty much the same. So from that point of view, again, it comes back to the point that we are headed towards a community-based accountable care structure and care delivery within our country. And those differences that we may find striking initially will eventually become very similar as we move toward the community-based healthcare. It's been said, and probably is true from our own experience, healthcare is local and healthcare is personal.
Thank you. All right, Katie, take it away on differences.
Yeah, so in reflecting on some differences between MSSP and MA in my career experience, one of the striking differences that came to mind for me was the payment mechanism differences to providers. So I've spent some time in my career working for one of the large top 5 Medicare Advantage companies, and when I worked for that company under value-based contracts, we provided incremental incentive payments to physicians, not to the healthcare system, not to the ACO, but actually checks written to the physician based on their performance improvement, in addition to a potential shared savings payment at the end of a year period of time. Wow, we had so much more physician engagement under that model. And, it goes back to just traditional behavior modification, right? We're asking providers to change some of their practice patterns and to, check more boxes, as they say, and, account for and think about total cost of care of their patient rather than just the clinical aspect of that care. So we need to incentivize them to do that financially. Plus, independents and even employed providers are struggling, and they need that financial incentive many times. So under MSSP, we don't have that luxury under traditional MSSP tracks. You maybe get a shared savings payment if you're lucky your first year or so. A year and a half after you start the program. That doesn't account for the time that it takes to build the ACO and the financial capital that's required to do that. So you're asking your physicians to do a lot of work for a long time without giving them any financial incentive under MSSP traditionally. So I think those are two really stark differences that create a problem for us as leaders of these organizations, and we need to think about solutions to that. Perhaps how can we leverage our relationships with MA companies to help support the MSSP programs to incentivize physicians overall? How can we leverage our relationships with the health systems that the providers might be employed under, or yourselves as the ACO or MSO to provide some type of financial incentive incrementally to your physicians that you're working with?
Absolutely. Incentive is really important, because if you're not aligning your incentives, things are going in a different direction. So having those payments up front or incrementally is really nice to see for a provider. Do you tell them that these incremental payments are for a certain program that they're involved with, but this isn't MA work, or this is for this particular contract, not for your ACO work? Or do you just say, this is for your value-based efforts putting forward?
So Vanderbilt Health Affiliated Network is not actually doing that right now. I would love for us to do that, and we'll work towards that. But I can speak to my experience with Medicare Advantage. Each check was attached to a performance report that measured certain key performance indicators that were part of their contract. So they knew exactly, each provider knew exactly what their metrics were, and the payment applied to each metric.
Yeah,
and that was a quarterly payment for every physician.
Nice. So tying the report card of how they're performing to an incentive payment is really important to change their behavior.
Yes.
All right, so we come across our resources and infrastructure, some things that you might find that are necessary to fulfill these contracts, whether it's post-acute care or your data analytics or just working on compliance. What are some things that you've come across in your experience? And we'll start with Dr. Gray.
I'm going to embarrassingly ask you to repeat that question.
Oh, I'm sorry.
I was working
In the zone?
I was working on the next question.
Okay, so there's a lot of resources that you might need as a provider as well as an administrator who is looking at these two populations. So what are some resources and maybe some infrastructure that you would want to lay down, or you might be in the process of putting together to help with these two populations?
Well, I think one of the most important things that you have within the context of the ACO and its community-based origins is the analytical system, which will help define the care needs of a particular patient. I think there again, if you begin to recognize a unique bias here towards the center of the universe, the newly defined center of the universe, I offer no apology, because it used to be, and not so long ago, in both my real and professional memory, is that the hospital used to be the center of the healthcare universe. The hospital today is a cost center, and the patient is the center of the universe. So anything, any resources that you have within your organization that focuses its attention on the patient, such as your analytical tool, your business intelligence analytical data visualization tool, becomes the center of your administrative universe in defining the needs of that particular patient, or in a larger sense of your particular patient group. So the tool, in my opinion, most essential to achieve that objective is your analytical system. And just a fleeting moment of shameless commerce, borrowed from the Kartok Mariachi brothers of NPR. And that is the Salient tool, Salient Data Analytic Tool, SIM, Salient Interactive Miner, or dashboard tool, is just that kind of tool that will begin to centralize your thinking and in managing that particular patient. Now, there are lots of others and lots of other very good ones as well. But I just wanted you to hear those words in this moment.
Thank you. All right, Katie, so what are some resources that you guys have put together or infrastructure that you've built up for managing these populations?
So for Vanderbilt Health Affiliated Network, it's a very large network comprised of over 6,000 providers, independent providers, hospitals, post-acute care facilities, and under commercial, MA, and MSSP contracts, there's over 300,000 lives managed. So when we think about infrastructure and the infrastructure it takes to effectively manage value-based contracts for all of that, it's expansive. One thing that VAN did originally was build all of its infrastructure and resources locally in Nashville. And so while there's a very large department of population health and multidisciplinary teams that work with all of these contracted providers from Nashville, it was effective, but the leadership realized that to be most effective, we need to build regional infrastructure. And so that's why I was added to the team, actually, to manage the West Tennessee and Mississippi markets of VAN. But so you know, don't forget, I guess my advice would be the value of relationship and how the work that we're doing is very personal, and we need to have personal relationships with patients directly and the providers and health system administrators that we work with, and that means being local and seeing those people face to face, you know, on a regular basis.
You once told me that you were working on a program to incorporate social determinants of health.
Mm-hmm.
What have you done around that perspective as a resource to your team?
Right. So one thing that VAN has recently added to its disciplinary team is a whole transition of care support team led by a transition of care director that has social workers, licensed clinical social workers that report to her. They're also adding community health workers to help just aid patients that are having, you know, social support needs. We found through care coordination, not only at VAN, but I can certainly speak to this, to my experience as a whole, most of the patients that you encounter through traditional care coordination services have some type of social support issue that is happening that is causing them to have you know, higher readmission rates and more chronic exacerbated conditions. And so we can't ignore that, and I really have been pleased and glad to be a part of a team like VAN that is tackling that head on and building specific social service support team members and deploying them locally in our markets to work directly with patients and providers.
Yeah, that's a really nice resource. Mm-hmm. All right, David, so what is some infrastructure that you've put in place to help these physicians manage their populations?
Yes, so with us having a much longer experience with MSSP, it was kind of a huge transition to have more of a gatekeeper model with Medicare Advantage. And you know, we really prioritize the PCP management of referrals and oversight of the gatekeeper model and less of the insurance side. But, we didn't have the personnel at the PCP offices to be able to manage that and timely be able to get decision-making and referral management. So that was a big change that we're still taking on. And just to reiterate Dr. Gray's point is, you don't realize how costly the nuances of reporting are. So, when you have an analytics system that you've educated your physicians on, and by the way, as you know, the physicians are brilliant at evaluating themselves and your tools. And if you're just a few decimal places off on how you calculate your risk adjustment, your per member per month, your episodes, it can really plague the trust that your physicians have in your tools. And if your staff has to remember that this system is different than this system, and this report looks different than this report, it can really plague your operations. So we've made that mistake in the past, and from now on we always use one analytics company to manage all of our contracts.
Great, thank you. All right, so we move on to negotiation. I know this can be a really touchy subject, but Medicare is, as I said before, the gold standard. They're not changing or wavering. So it's your job to work with some of these payers to find wiggle room where you can. So what kind of aspects do you kind of hone in on that are more important to your organization versus some others that you might just let slide for the time being? And David, I'll let you start off with that one.
Absolutely. So, as the provider, often these contracts favor the payer. You can typically sense which parts of them are black box. So, they have all of the control of the metrics of MLR or benchmark, and you can typically pick up on that. The one that we pay a lot of attention to these days is trend or inflation. So you want to be sensitive that if your market's going up by 5%, and you have a hard-coded inflation of 2%. That's a pretty enormous loss to your group and something you got to pay attention to. But, as a provider network, we don't always have the leverage. So what's really worked well with us in the past is that, we do the best we can to negotiate the first time. But if we perform really well and we're really great partners to the payer, after a year, if our contract's not perfect, we can typically renegotiate. And the payer's apt to do so because they don't want to lose us as a partner. So that strategy's worked well. We've renegotiated 2 contracts where it wasn't perfect at first, and we were able to make it a lot more fair for everyone.
Nice. All right, Katie, some aspects that you've worked with in negotiation.
Yeah, I would just reiterate David's point in that, if at first, you don't succeed in obtaining the contract terms that you would prefer, don't give up because payers, again, coming from that side and that perspective, having that as well, they're noting those that don't renegotiate on the second round. So please, make sure to negotiate all terms, even those that you feel like fall into the black box, because once you've established yourself as a good partner and a collaborative, provider network to work with, that's what means the most to payers. And, they have a lot of flexibility, especially under, your MA contracts. So, partner with them, befriend them, and talk to them about your sticking points because, from my experience, they'll work with you on that, definitely. One thing that Van is interested in doing is aligning as much as possible, and I stress it as much as possible, the quality measures across all of our contracts to align with MSSP reporting and with MA and commercial contracts and potentially Medicaid on the horizon. We need to be streamlining as much of our quality reporting as possible so that as we educate and build systems and analytics and reporting functionalities for our providers, we're not having to teach them, check this box here for this plan. As Dr. Gray said, we want to make it as the same for all payers, for all patients as possible, and that really impacts the quality reporting component.
Yeah, making it payer agnostic for the physician is extremely important. Agreed. All right, Dr. Gray, your turn for negotiation points.
So I have two points. One is availability, access, and the other is to emphasize some finer points of quality. Now, in terms of availability, most of you have already worked on this. You've got offices that put a recording on Friday afternoon. You know, office is closed. If you have a problem, call 911 or go to the emergency room. Now, we all know that that's not appropriate care. Availability is a major administrative issue that must be managed in this modern world of accountability. So that you'll take care of, and that standard is across all of your patients, whether they be ERISA-based, Medicaid, or Medicare of either type. So that's one thing that has to happen. So what you're seeing then, what you're seeing is an increased standardization. Now, it's interesting, I wrote a blog recently about asking the question, is the ACO initiative setting a new standard of care in our medical communities? Now, a standard of care from a medical legal point of view, and the answer is yes, it is. You're setting a new standard of care in terms of availability and in terms of patient management. But the other issue, I think, is overarching anything else, and that is the issue of quality. Now, we have 90 HEDIS measures. We have 32, 33 measures within the context of the ACO of quality measures that you have to achieve. And the objective here, initially, when you move from MSSP to MA is to try to get as many of those quality issues to be the same. Now, I will suggest, and you intuitively will know, that eventually we're going to see a standard collection of quality measures that we as providers, whether we're administrative or clinical, are going to have to achieve in order to be successful financially or clinically. It's not just financially anymore, it's financially and clinically. And those quality measures are our standards as we move through this process. So the importance in your negotiations of achieving a high standard within the ACO limitations, those key performance indicators, of achieving that, and being able to deliver that to your new customer, which is the MSO, the managed care company, the MA company, the importance of being able to deliver that, and to deliver an added amount. Now, you got to be careful, and we all intuitively we all understand this. You've got to be careful. You cannot overload the system, because it makes the system numb as to what your objective is. And the objective clearly is the triple aim: better care, lower cost, higher patient satisfaction. You got to achieve that. So you have to move incrementally. So as you're in your negotiating process, you're going to have to give and take, add some additional quality measures to the MA group, even though they're not covered under the MSSP. But keep in mind that both organizations are headed in the same direction. Whether it's MA or MSSP, you know the pathway to success already. It's already been outlined. We are going to be accepting risk at the community or practice level very soon. And we are going to be accepting reward for the performance as well. So know where you're going on this as you begin those negotiations with the MSSP, with the MA companies. Understanding what your quality achievability is within your organization. Work it out in advance with your physicians to know, so they know there'll be additional quality measures coming on board. And then go to the negotiating table from a strong position of knowledge, of understanding of your organization and what its capacity is, achieved through personal relationships that you have Oh, I can't emphasize that enough. Achieve that through the personal relationships you have within your physician community, because they are the ones that will make you successful.
Yep.
It happens at the bedside. It happens at the exam table.
Absolutely. And I think it's really important that your providers understand that your administrators are going through these contracts and trying to find what's best that works for them. I'm actually kind of curious, after they announced that they're doing the direct-to-physician contracting, how well that might go on that end. But it's a highly valuable statement to say you have ACOs with administrators that are helping to work on that front. So the final question leads us to ask them, what's on the horizon for your organization? Are you branching out into maybe other payers from your experience? Are you looking into Medicaid or ERISA or some other contracts? So Katie, can you lead us off there on what's on the horizon for VAN?
Sure, I'll be glad to. So VAN is interested in expanding to Medicaid. That's the one population that we don't currently have under our management, and certainly there's opportunity for that in our southern states. We've proven ourselves well and to be successful in managing pediatric populations under commercial contracts, and so certainly, it seems logical that we would move into Medicaid. Other things on our horizon or that we're currently doing now are starting to roll out across the network as a whole, not just with MSSP, but inclusive of MSSP, would be the development and implementation of what we refer to as care pathways. So we have a robust physician leadership council for the network that represent each of our regions throughout the states that we represent in our network, and they're working collaboratively to develop standardized treatments for costly medical conditions and those that we are measured on for quality. So those standardized treatment plans will be not written and exclusively published by Vanderbilt, but as a representative team across our whole network. We're real excited about that, to move into a real clinically integrated network type model of standardizing care and working collaboratively amongst many different tax ID numbers to share patient information and treatment interventions. Another interesting thing that we're doing that I think could be applied to any organization, large or small, or whatever your type is the formation of learning collaboratives. So, we've got lots of different hospitals, independent providers of all different sizes and types, and we're bringing those groups together to talk about post-acute care interventions and have each of those systems share what they're doing with each other, to learn from each other. And that's launched first for us with post-acute care learning collaborative, and it's proven to be high level of engagement and appreciation. So we're excited about continuing that learning collaborative with different topics throughout the year.
Yes. And David, what's Palm Beach ACO up to on the horizon? What are they working on, and are there contracts that you're working on currently?
So it's been a really stark reality for us. Even the rules said that in 2011 that we must take risk. We now actually have to take risk. And it's interesting is that the MSSP is risk, but now 6 out of our 7 other payer contracts have mandatory transition to downside risk. So we've really had to tighten up the organization, the infrastructure, particularly the network, to be able to change our business model. But it was a big reality. You must take risk to be an ACO. To be clear, the big things we worked on is we raised capital. We were it was really fortunate that our physicians backed their own company, and we were able to raise all of the repayment mechanisms for all contracts completely by physician investment. So, boy, it's incredible stake in the game. It's really been an awesome amount of engagement. And then the second thing is we've had to narrow the network. So just in the last 6 months, there's been 30 practices terminated. They got second and third chances, and they just refused to change. So as kindly as possible, we asked them to sit out and reapply in a future year with the expectation that many of them will come back ready to work now. But that's been an enormous transition for us, and we've been preparing for a long time and now making that move.
And you've had a lot of data to see who's performing, who isn't, and help them share, where they're going, their scorecards, all of that.
Well said. These decisions are data-driven. They're objective. They're based on policy. It's not based on friends, and it's nice to have partners that can assist us with those tools.
Absolutely. All right, Dr. Gray, what's on the horizon for you?
Well, on the horizon for me is that I just bought a new tractor this year, and I'm anxious to put it to use this summer. But there are a lot of you who have similar things on your horizon as well. But the point here is anything that I might say about Salient, it applies to any vendor that is currently supporting you. And you, as a customer, must demand the kind of service and support that you need to move forward. You already see the speed and the direction that the marketplace is going, and your vendor must be ready to support you. Now, I've suggested throughout my conversation this morning already that the community-based ACO will ultimately be the care provider for that population, whether it's Medicare, both types, whether it's Medicaid through an ACO model, and whether it's an ERISA-based program. You, as a community, care for this population. It is ours, it is yours. So your vendor must be able to supply Medicare, MSSP, which will ultimately come risk-bearing, and the similarities and relationships between MA and MSSP will begin to diminish. Whether it's Medicaid in an ACO model, which we're already seeing, and in fact, Salient has already supported one, a Medicaid ACO with a combination of claims, clinical data, and early elements of social determinants rationalized down to the beneficiary level. That's the level of support that you are going to need. Because as you take a risk, whether it is in Medicare or Medicaid or ERISA-based models, don't think that there's going to be any left behinds here. It won't be. But you know that already. You have to be able to support them, and that's what your vendor must be able to do. Now keep in mind also that these populations are different. Medicaid is clearly different. Medicaid is pregnant women, kids. 60% of kids in your state, practically all states, are supported under Medicaid, and the developmentally disabled population, and a few others with complicated, extremely complicated so-called duals and others. That's what Medicaid is. You have ERISA-based people. You are ERISA-based population. And that's a different population than the Medicare population, which you are currently focused on. So that's what I see in the future, is you must be able to support those populations on a single platform. That's right, a single platform. Medicare, Medicaid, ERISA-based programs. Support on a single platform where you can distinguish the populations, where you can aggregate, where you can rationalize down to the beneficiary level. You're going to have to include certain specific elements from your EHR, and you're going to have to include the social determinants that affect your population. Your vendor must be able to supply that to you. Because as you move towards risk, we are going to need this in order to support the population at the intensity and level that's going to be required of us in the future. This is a whole new ballgame. And I think your relationship with your analytic vendor becomes commercially intimate.
All right. Well, I want to thank all of our speakers for joining us here on the panel. And I want to open it up for questions. If any of you have any questions, please ask away. All right, let's begin up here.
Quick question for David. As a physician in Virginia, not knowing your MA saturation in your environment, have you entertained the idea of creating your own?
And please repeat the question.
Our own, so is the question that, are we considering doing our own MA plan? It's a great question. Where we are right now is that we partner with the payers, and we're a little bit skeptical as to how they will see us differently if we're just the best providers in the area and we're willing to work for all payers. We wonder if that's a better position than if we actually say that we're also a payer competing with payers. So it's a difficult conversation, but that's where we are right now. Is we'll work for all of you. You pay us fairly, and we'll provide you the best care, but we will not compete with you on your front. But it comes up significantly.
Absolutely. In the back.
So at first, no. So these contracts are well crafted by analysts and legal teams, and the payer has very little risk. But once they see that we're engaged and performing, they will absolutely pay you fairly. So if after the first year they find it's not reciprocal, the amount of work and the amount of compensation, and they feel like they're going to lose you, they'll absolutely change the terms to be more fair. It's we've been very impressed with how good of partners the payers have been.
What volume of their beneficiary base do you have to have for you to be important?
I think as soon as you hit the critical mass for them to do a value-based contract, I mean, if you have 5, 10, 15,000 lives, then they look at you as a real entity. We get a lot of concessions over time, and we're no more than 25% of the market in some counties and 10% in others. So I don't think you have to be a big fish. You just have to be big enough to meet the stats to get a contract.
Dr. Gray.
I want to address your question specifically about physician organizations being involved in developing health plans. Well, it can be done. I say this modestly. I have done it with physicians in Asheville, North Carolina, who developed their own health plan for themselves, their employees, and their families. Started in one county, went to 5. Very successful and very easy to manage, because you call up, you make a phone call to Roger, your neurologist in town, who's doing a procedure it's a personal phone call. Hey, Raj, what's going on? And then you immediately can make changes. So you have very close management of that. It is possible. And everyone in this room is a smart person and have the capacity to figure out how to do this insurance business. It's not that hard. There is risk involved. That's the thing that physicians generally are risk adverse. But we are all teachable. And over time, we will develop a relationship that's shifting from supportive to being supervisory and being able to run the company. And it begs the question, what service, what are you providing in the context of our relationship that I can't do myself? Is it claims adjudication? That's not hard. There are systems available, easily available to do claims adjudication. Is it the quality? No. We are the quality, and we are the ones that are providing that. But it takes a high degree of self-discipline, which may be that organizational effort that you, as ACO organizers and administrative people, will have to provide. So don't give up on your idea, Maybe not right now, but our futures run very short, don't they? We're not out 10 years, and we're out 3 to 5 years, and we will begin to see exactly what you have in your mind as to what might happen. So you're hearing encouragement from this chair.
I would also add, from my payer experience, don't let your volume and total attribution that you may have in your market area today prevent you from reaching out for an MA contract with a payer, because payers are looking for good provider partners. They can always grow their business in your market area and with your practice specifically. The MA company that I worked for, we had identified good provider partners, and during open enrollment period, we had tables in their lobbies. Business can be grown. What they need and are hungry for are eager, willing, engaged provider partners. So they'll grow with you, and if you let them know that you're interested in developing a long-term relationship with growth, I don't think that you would be disappointed with their response.
And use your ACO data to say, look how great we do with our unmanaged population. I mean, these people don't have a network. They don't have a preferred referral system. So saying I can have an ER per 1,000 of less than 500, I mean, those are some nice numbers to show MA payers to say, we do really well with this population. How can we work with you for a managed population? All right, thank you. So now let's do our drawing and see who wins the gift card. How do I reach in? Okay. All right. The winner is Brenda Stiles from the University of Vermont. She here? No? All right, Brenda is not here. Next one. All right, we have Lauren Valinati from South Nassau. Yay, congrats.